what I have done is in the coming 1 month, since breast cancer is the main thing for student, breast and oral cancer, I have posted about three topics. There is one topic where how do we manage approach LABC, which Dr. DG Vijay is going to cover it next month, and I'm going to cover myself two topics. One is how do we manage the axilla in breast cancer, what are the recent trial landmark studies which needs to be covered, how do we approach them, what is the philosophy behind them, and the other topic is what is the impact of neoadjuvant treatment in breast cancer, and what is the philosophy general principle. I think about 3 or 4 weeks from now, I'll cover the second topic. So today's topic is something which is very important and paramount to understand various evolution treatment concepts in the management of axillary nodes in breast cancer. So we know that currently the whole treatment in oncology, more so in breast cancer, is not to bombard somebody with maximum treatment, not maximum surgery like radical mastectomy, not maximum chemo for everybody just because they are node positive, not full dose radiation to everybody, and not entire, a combination of anti-HER2 therapy all the time to always. Now, this is not an era of maximum tolerable treatment, but this is an era of minimum effective treatment. Now we have moved to de-escalation in all the three components of breast cancer treatment: surgical, medical, and radiation. In surgery, we have moved away from radical mastectomy to modified. From modified, we have now moved routinely to breast conservation surgery. Almost 70-90% of the patients are eligible for breast conservative surgery, and it is now proved that breast conservative surgery has not inferior to mastectomy, maybe marginally better in terms of outcomes. And even in case of axilla, we have moved from blanket axial lymph node dissection to sentinel lymph node, minimal invasive approach. Even in those patients who are sentinel node positive, now all patient doesn't need complete ALND, axial lymph node dissection. There is a group of patient where you can avoid even though sentinel node is positive. I'll cover this now. Also, women who are above 72 years, if their luminal A, if axillary ultrasound clinical examination is normal, there is selected group, it can be omit as per the new evidence and guidelines that has come. Even in the patient who are node positive before starting chemo, if you have clipped and targeted the axilla and then you give chemo and sterilize the axilla, which happens in 60% of the cases, you can go back and actually do a targeted axillary sentinel node and still ALND is not mandatory. Similarly, de-escalation of treatment has happened in radiation. We moved from conventional 50405 weeks adjuvant radiation to hypofractionated 21. From hypofractionated, we have moved to 2 weeks. Now people are moving to fast forward 7 days radiation and intraoperative, intra-beam, and various type of radiation therapy and APPI. So there is a de-escalation that is happening in all. Even in chemo, if patient is luminal A, rarely we give chemo even if they are 2 to 3 lymph node positive. Even if somebody is LABC, but they are elderly, postmenopausal, luminal A node negative, they still we may not give chemo. We may use a genomic profiling and then avoid chemo if not required. So there is a de-escalation in entire breast cancer gamut and spectrum. So this is an era of minimum effective treatment, yet not compromising the cure rates, cosmesis, and quality of life. This is something we must understand. So this is a very important thing which I have taken from the Lancet, where any treatment when you do, there is an ideal line. Any treatment which is above is mutilating, any treatment below that is conservative. So if you see that initially during the Halsted era, people thought radical mastectomy is very, very important. So they went aggressive, gave a lot of side effects, low quality of life, and achieved a good loco-regional control, but didn't make too much impact on systemic. Then came the Fisher's hypothesis from Halsted, which Halsted told the cancer spread systematically. Primary, it expands, then to lymphatic, then to node, then expand, then to supraclavicular node, then to blood, then to systemic. That was the Halstedian hypothesis. Then came the Fisher's hypothesis, who is the father of NSABP trials. He is the father of all NSABP trials, who told early breast cancer, even when node is negative, maybe 1 to 2 centimeter, it could still be a systemic disease. Any breast cancer, invasive cancer, more than 10 millimeter is counted as per Abeloff definition, Abeloff textbook of medical oncology, and as per most of the NSABP trials, Fisher's hypothesis are considered to be systemic disease from origin. Even if node is negative, they need some form of systemic therapy, either chemo or hormone therapy. So then the Fisher brought this hypothesis. It can bypass the nodes, bypass the lymphatic, still they can go and have an access to micrometastasis in the blood and systemic metastasis. Then people thought, oh, then no need to do axillary clearance, and dangerously people started doing conservative surgery like tylectomy, lumpectomy with not with close margin, not addressing axilla if clinically they looked N0. Then the survival significantly dropped down. That is this line of ideal line where we were dangerously below. Then we understood the proper philosophy with evidence-based medicine, multiple randomized control trial. Now we know management of primary tumor, management of breast, management of axilla, management of node and systemic disease. So don't do anything which is unnecessary mutilating, which is radical mastectomy. Maybe now in this era, even modified radical mastectomy and axillary lymph node clearance, blanket chemo to all. Below, what is unnecessarily dangerous in a patient where you take very close margin, or when patient is eligible for ALND, not doing it and then washing off hands, or not treating the sentinel lymph node in eligible N0 patient. Just because they're N0 doesn't mean they're truly pathologically N0. 20% of them could be microscopically positive. So these are the line which you need to understand and master. So this is William Halsted, 1922. Very important to understand, his concepts, especially the landmark trial NSABP04, which he brought, gave lot of answer and lot of importance, which I'll cover. But then we moved to Fisher hypothesis, which is the father of NSABP. But as of today, as an oncologist student, you must know there are only 3 diseases in the human body which still respects Halsted's principle of spread. Primary, it increases, becomes advanced, goes to lymphatics, then it goes to node, then only it goes to higher node, then it goes to blood, then systemic mats. And local, regional, systemic. The 3 such diseases: squamous cell carcinoma oral cancer, squamous cell carcinoma vulva, squamous cell carcinoma cervix and vagina. Even today, these 3 particular disease subsets follow Halsted principle. In oral cancer, without a lymph node metastasis, oral squamous, there will never be a systemic metastasis. This is not oropharynx or hypopharynx. It will never. So similarly, in vulval cancer, if there is no groin node metastasis, there will never be a systemic metastasis. So these diseases still respect Halsted. Rest all are Fisher's hypothesis. So William Halsted, 1900 to 1975, who popularized radical mastectomy and then ALND. Then came Bernard Fisher, father of all NSABPs. Then came Armando Giuliano, who brought the Sentinel node. So understand the evolution of these 3 people, which is very important. And when you read NSABP, please go to the NSABP website. You get a printout from NSABP 01 till to the current NSABP. You must know what it is done for and what is the difference. Like NSABP 04 suggested complete ALND. If you do, all you need to do is remove 12 nodes, 10 to 12 nodes to know a therapeutically they are negative or positive for staging. The moment there is a node which is positive, if you remove 15 node, then the recurrence of axilla drops down to less than 3%. If you remove less than 10 node in a positive axilla, the recurrence is 30%. So these are all the concepts brought by NSABP for Halsted, and NSABP 018, 016, which brought breast conservative surgery equivalent to mastectomy in pre and postmenopausal. Then Danish breast study 35B, DNBC 36. You need to understand, read all these particular trials to understand. And NSABP 09, which actually told neoadjuvant chemo in eligible patient, downsizing and doing breast conservation has a better survival. So, why it is safe. This is what paper which I published, analyzed in Indian scenario of the patients. What is the chance when you do a breast conservation and follow it up to 20 years? What is the chance of recurrence? And you can go back and read this paper in Indian context of patient I brought, and the ipsilateral breast recurrence in breast conservation group is less than 2%. So it is safe even in Indian patients. Now coming to the axilla, what is the issue with the axilla? Axillary treatment is extremely important. Remember, initially people thought axillary treatment is both staging, therapeutic. which means therapeutic means if you do axillary clearance, prevent local recurrence. If a patient is a low risk tumor, for every 4 recurrence you save, 1 life is saved. If it is high grade, high risk breast cancer, so then for every 2 recurrence you save, 1 life is saved. 1 is to 2, 1 is to 4. So people thought in old era where chemo was not routinely Taxol, pertuzumab, trastuzumab was not routinely used. Axillary treatment was both staging, prognostication, node positive, node negative, less than 4 negative, more than 4 negative, node positive, 10 node positive. And also it reduces the local recurrence. Initially it was thought that axillary lymphadenectomy was therapeutic. So axillary address subserves all these 4 points. But what is important is even when you clinically don't palpate a node, even when ultrasound of the axilla is negative, even a tumor as low as 1 centimeter, there is a 25% chance of axillary node metastasis. So you have to stage the axilla either by Slnb or by a axillary clearance if you don't have that facility. Remember, as per Avalov textbook of medical oncology, any tumor which is more than 10 millimeter, 1 centimeter and invasive, unless otherwise proved, needs a systemic therapy and thought to be an advanced cancer. 10 to the power of 16 cells, if you have, that is no longer a early cancer, it is an advanced cancer. You can read the definition of what is EBC, early breast cancer, LOBC, large operable breast cancer, LABC, large, locally advanced breast cancer, operable, inoperable, MBC, metastatic breast cancer. So you need to know all this term as a student. But elective axillary dissection accomplishes the staging, but at a cost of lot of complication. Remember, axillary sampling, just going and picking level 1, 2 is not accepted as a high level of evidence, because the morbidity of simple axillary sampling sometimes is as high as a systematic ALND in terms of lymphocyl, brachial neuralgia, lymphedema. Yet it may not be adequate because 5 to 29% of the time there is a skip metastasis to level 3 rotor's node or high level 2 you may miss. That's why SLNB or axillary clearance, but a random axillary sampling is still not a level 1 evidence. So when you do a systematic lymphadenectomy, level 1, 2 and 3 intercostobrachial nerve, there are multiple trials telling to preserve intercostobrachial nerve or not if it is clinically N0 and you don't have a facility of sentinel lymph node. Because the reason is you may do a thermal damage and the neuritic prime may be very bad, or it may get trapped in fibrosis and the function of it may not be good and it may cause more harm than not. So nevertheless, read about this trial comparing to preserve the nerve or not. You must know the both sides of coins. Now students always ask, sir, should the ILND be level 1, 2 alone or should we omit level 3? Level 3 because infraclavicular node at the Halsted, costoclavicular ligament, Halsted ligament may add a lot of morbidity without benefit. The answer you should say is, if you are doing a axillary clearance for staging in a clinically N0 neck, then you should do sentinel lymph node. If you don't have sentinel lymph node, then level 1, 2 is adequate. If you are doing for a therapeutic axillary clearance in a positive proved axilla or an LABC, it has to be systematic level 1, 2 and 3. This is the answer you are supposed to give in exam. Remember this. Okay, so once you do this, this is something which is very important, that if you follow the evolution of axillary lymphadenectomy, if you do 100 people lymphadenectomy, 30% of the time only node is positive. So they are the candidate for sentinel lymph node. Between 1900 to year 2000, most of the people have sentinel, ALND. Come year 2000, most of them have, SLNB. Then came Asakov, Z11. Then most of the patient, even if sentinel node is positive, residual tumor burden load is assessed. Nomograms, MSKCC are put. Then we found that similar DFS OS is there and there is no extra axillary recurrence. So this is an evolution in the field we have. Now if you do systematic ALND, what is that we accumulate? T1, T2, 70% of the time no node involvement, but 50% develop complication. What are those complications? Lymphedema in 25%. We have published from our group lot of studies in India. In India, if somebody asks what is the incidence of lymphedema after ALND, it is rated as 25% in India. Sometimes as high as 30, because whether you added radiation or not, high BMI obese patient or not also impact. But in India, current rate of lymphedema in ALND is 25%, may go as high as 30 to 40 if radiation is added and patient is obese and has other comorbidities. Intercostobrachial numbness, I showed that now is 78%. That nerve goes at the level of angular vein. Some other time I'll take an operative session on how to do a good MRM and what are the tips and tricks. You can visit my YouTube, it is available, but I can run a 1 hour course of all the pros, cons, do's, don'ts, how to do a good modified radical mastectomy and ALND. So this now comes at the level of angular vein, where the nerve to thorax, nerve to serratus anterior, long thoracic nerve of bell goes in and the angular vein comes out. That vein joins the thoracodorsal pedicle of the vein. That is where the intercostobrachial now exit. That's also an area where if you look at the almanac trial brought by Professor Robert Mansell of 4-node blue node clearance, that is the limit of the node clearance. Then restricted shoulder mobility in 17%, paresthesia, seroma, prolonged hospital stay. These are the morbidity. Remember, the most dreaded irreversible complication is lymphedema. Very dangerous. It can also be a pre-malignant skin changes, and lymphedemas directed surgery are required. So this is one of the reasons. These are the landmark publication which quoted lymphedema, frozen shoulder, sensory abnormality. So 50% of them will have this complication. Very difficult to justify. That's why we came to the concept of Sentinel. What is Sentinel? If you go to that old Killa, you have a big fort. At the entrance of the fort, there is one top highest point where there is a guard who is standing, and he has a gauge as far as 8 to 10 miles. So even if you see an army coming 8 to 10 miles away, he is the sentinel, a guy soldier who guards at the tower, which is the highest point of that fort, who can see the first. So in the name of this, we call sentinel lymph node. So it is the first lymph node which receives the cancer, and if that is negative, other nodes are negative in the axilla. That is the concept. So remember, sentinel node is not fixed for all human beings. Even in a given patient on different, both breast, it is not same. For a given patient, for a given breast, it is common irrespective of which quadrant the tumor in that breast is. So now these are the phenomenal 10 to 12 randomized control trials which I showed in T1, T2, T3, clinically N0. You have to do a sentinel lymph node. If you don't do, as per the ASCO, it is crime not to offer sentinel node in this era. So these are the papers, please go back and read. But I'll analyze certain important trial. NSABP B32. This is the one which showed sentinel node has equivalent overall survival, equivalent DFS, and has a better quality of life and no statistical difference in axillary clearance. Almanac trial is different. It is a blue dye noted 4-node removal, which also compared, it is equivalent. So these are some of the landmark trial in Slnb. Now ASCO recommends how to do a sentinel lymph node. The way to do sentinel lymph node as of today, level 1 evidence standard of care is dual tracer. You have to use a radiocolloid technician with a handheld gamma probe and any blue dye. Any one of them alone is not a very high technique. So it is a dual technique, and lymphoscintigraphy image is not mandatory as long as you have a handheld gamma probe. This identifies the sentinel node in more than 96 to 97% of the time, and then the false negative rate is less than 5%. So these were all used even in Amaros and Almanac trial. Now ASCO has a rule who can do sentinel node. In an institution where both the facilities are available, and then the team, surgeon, pathologist, the radiologist, breast imaging specialist, and then the nuclear medicine doctor have done 20 to 30 sentinel lymph nodes, and they validated and axillary clearance, and the false negative rate, FNR, should be less than 5%. If the FNR rate is above 5%, you cannot and should not practice Slnb. Having said that, most of the center who have done thousands and thousands of Slnb, FNR rate is somewhere around 3.5 to 3.7%. Same applies for sentinel lymph node after neoadjuvant chemo. So what is the golden point? CAP guidelines. It is called as American College of Pathologists guidelines along with ASCO, and you must understand this particular technique. This is one of the first trial in India which I published. 2001, I started the Sentinel node, where we switch over from commercially available isosulfan blue, vital blue, which was not available. We had to import from UK, but we used a Indian available methylene blue sterile ampules, which are used in ICU to give for methemoglobinemia poisoning. And this was the first study ever which showed methylene blue has an identification rate very high, and false negative rate was 3.7% in Indian set of patients for 100 patients in early breast cancer, which I did and published. Subsequently, people have switched over to methylene blue. So, what are the important concepts in Sentinel lymph node? So, I will take you through the concepts, method, site of injection. Should we do neoadjuvant chemo setup before or after? And if it is positive, how do we follow? So, this is what I told you. The common mistake people do is when you use a blue dye, when you go to the axilla, you find 2 to 3 blue node and you think they are sentinel node and remove. But remember, they may be the second echelon lymph node. Can you see this second echelon lymph node? The first lymph node could be between the axillary tail and the sentinel node you harvested. So whenever you pick up a sentinel lymph node, remember this, it is extremely important to understand what when you pick up a sentinel lymph node, blue dye or a technetium hot node, blue node, hot node, always search between the axillary tail and this node you picked up to see in the level 1 or the process of axillary tail there is another node that could be the important sentinel node. And if you don't pick it up and pick the second tier, second echelon node, you may think they're negative and erroneously put it as N0, and you may actually miss the first node which could be positive. So this is very important to understand when you do this. So sentinel lymph node biopsy is considered as a standard of care to assess the sentinel lymph node currently, and it is a level 1 evidence, but you must know how to identify it. It stages the axilla properly. If positive, it will add prognostic implications, and you may, if by identifying them, you may switch over from conventional chemo to Taxol based chemo. You may add radiation tailor-made the adjuvant treatment. You will prevent the axillary recurrence, and in some cases, it could be therapeutic. So this is the very important thing. Sentinel lymph node on frozen section is negative, no need for further clearance. If it is positive, based on what trial, what is the patient characteristic, we do it. So current guideline is any patient invasive breast cancer less than 5 centimeter, clinically ultrasound axilla negative or level 1 candidate for Slnb. So these are the various guidelines, and I told you the ASCO guideline, 20 cases you must do, validation study, FNR rate should be less than 5%. Now we will look at it, how do you do with the dye? There are various dye, isosulfan blue, patent blue, ICG, methylene blue. Now it is proved that based on various trial as a student, whichever dye you use, now it doesn't matter, all of them have same sensitivity specificity. So the chapter is closed. Vital dye or non-vital dye. Now technetium. Should we use colloid? Should we use albumin? Should we use technetium, sulfur? Should we use dextran? Again, it is proved by all this study, it doesn't matter which dye you use, as long as you know with your nuclear medicine person what is the molecular size and what is the time taken, they are same. For example, the right molecular size in technetium should be between 230 to 260 nanometer. If it is less than that, very fast it goes to all the node. When you open the axilla, if you keep a handheld gamma probe, it produces hot sound everywhere and you don't know which is sentinel node. If you use an albumin bound thick molecule, it takes like overnight to go and it may not reach. That's why if you use albumin, high molecular bound, radionuclide colloid, you have to give an overnight injection. If you use a technetium sulfur, which is around 260 nanometer, you can do it 2 hours before. So that's why you must know the duration and time which is fixed on whichever molecule used. All of them are same. So these are all the studies which showed based on which dye used, there is no difference in identification rate. So isosulfan blue, patent blue, sulfan blue, sulfane blue, patent blue, methylene blue, all are same. This is what we also published and I showed in Indian scenario. Handheld gamma probe with technetium sulfur colloid 2 hours before and methylene blue. Identification is very good. If we had not used a gamma probe, 87% alone with blue dye, we would have missed roughly about 13%. Second issue, where do we give the injection? Should we give it peritumoral? Should we give intradermal? Should we give subdermal? Should we give intratumoral? Should we give to retroalar sappy plexus? Now it is again proved, irrespective of whichever quadrant the tumor is, upper, inner, upper, outer, central, lower, it doesn't matter where you inject, all of them are same. That's why now everybody has switched over to single 3 ml injection into the retroareolar, subareolar, not intradermal. Remember this. Otherwise, skin necrosis will happen in methylene blue. 3 ml is adequate irrespective of where the tumor is. That is now the most popular technique. So these are the safety. Now remember, if you have a breast cancer patient, if you are doing a clinical trial, if somebody asks what is the median time a breast cancer tumor can recur in the breast, the answer is, if a patient is triple negative, ER negative, if they don't recur within 5 years of completing the treatment, they will not recur later. They are considered cured. If a patient is HR, hormone positive, they, even though they may be fine at 6-7 years, they have late recurrence as late as 10 years. So they are not considered cured until they are followed for 15 years. That's why extended hormone therapy of 7 to 10 years has come, because even though they fine 7-10 years later, they can recur. So it's very important to understand this concept. Okay. So if you do a study for breast cancer primary tumor, you have to follow them for 5 to 10 years. 5 years if they're hormone negative, 10 year to 15 if they're hormone positive, to identify all the recurrence. But axilla recurrence is not like that. If you have done something wrong in the axilla, false negative, you have missed it. All the axillary recurrences happen median by 20 months. Remember, 20 months. Roughly 1.5 years, all the axillary recurrence manifest if they're going to recur, and by almost 40 months, all recur. This is a study of 14,995,090 sentinel node negative patient. 0.3% is the axillary recurrence. So it is very safe. In the world, you can see how many cases has been studied. 14,95,090 sentinel node negative followed for 10 years. Axillary recurrence is 0.3% only, and all the recurrence, if they happen in 20. So if you want to do a study in sentinel axilla, 20 months if you follow, you are through, you can publish that. Rightfully, this is a paper I published, I think this year, 2022, last year, where we followed 10,000 of the sentinel node. I did over 20 years in Indian patients in India, and then we followed all our sentinel lymph node negative patients, and the axillary recurrences time was 15 months. If anybody recurs, you can see as per my study of 10,000 sentinel node negative followed over 20 years. And most of them, if they recur, it was isolated axillary recurrence was 0.2%. So it is very safe even in Indian patient. Some myth. Multicentric disease is not a contraindication. You may have 5 tumor in one woman. Still you can go and do sentinel node. Multifocal, not contraindication. Previous lumpectomy done, cancer found, scar is there, they refer to you, not a contraindication. So there are very few contraindications for sentinel node. One of them is a complete axillary surgery done for, say, tuberculosis or previous. Even then people say that there is an aberrant lymph node, so you can still do sentinel node. You may pick up a sentinel node in level 3 or supraclavicular triangle of Ho, you can pick it up. That's why it's very important that there are rarely any contraindication unless it is at more than T3, clinically positive axilla or ultrasonically positive axilla. So these are the studies which shows multicentric tumor is not contraindication. Their false negative rate are still less than 5%. So please read this meta-analysis. It's a beautiful paper. I would request you to go back and do. So whichever blue dye use, it doesn't matter. So this is a paper I published, Indian Solution for Indian Problem, ABSI, Association of Breast Surgeons Guideline Consensus. Go back and read, it is updated. 3 such updates have happened over 5 years, and everything about Indian practice we have written. It's very nice to read and understand this particular paper. There are 3 papers which are available here. You can go back and read and understand what it means. All the practice in India guidelines are written. If you use a blue dye alone, about 15% of the time you miss it. Nevertheless, you can do it. It is quite good to do. That's why the concept of ICG came. The problem with handheld gamma probe, hot node, and then the blue node is the probe setting is very important. depending on whether you use Johnson and Johnson probe, Neo probe, or whether you are using a Euro probe. You have to understand, if you are doing for Sentinel node, once you give the primary site of injection, the probe setting needs to be 1:1 lakh. There is a gantry reading 1:1 lakh. When you keep it to the primary site of injection, whatever is the reading, 1:10 is the axilla. Once you remove the most hot node, 1:20 of the hot node background activity is the Sentinel node. This is the definition. I know it's tough to understand, but remember this is something important. Second, their static image. When you use a blue node or a sulfur colloid, unless you open the axilla, you can't identify the blue node and the lymphatics. And then you have to navigate across all the quadrant of axilla to identify the hot node. That's why it is not a dynamic SLNB surgery. It's a static, and you can miss and take second echelon node and think it is negative. First echelon sentinel node may be left behind, or you may end up digging more than node. If you remove more than 3 to 4 sentinel lymph node, remember the benefit of quality of life, lymphedema, minimal invasive nature, brachial neuralgia, seroma goes off. A badly performed sentinel node is worse than a well performed ALND. So the more node you pick up, sensitivity is good, specificity is good, false negative rate is good, but the benefit of minimal access and the quality of life goes off. That's why if you remove more than 4 node, you neither gave a benefit of minimal access nor you gave a benefit of complete axillary clearance. So typically sentinel node should be not more than 2, not more than 2, rarely 3. The moment you cross 3, take my word, no benefit. One sentinel node, if you remove, false negative rate may be more than 5%. If you are able to harvest 2 sentinel node, if it is available, then the false negative rate is less than 3.5. The moment you cross 3 and above, no extra benefit, but complication and seroma and lymphedema can still happen in them. That's why the dynamic scans, new technique have come, magnetic iron, ICG, various other technique has started now coming called as Sienna. They are all available in the market. ICG is something which is most popular because it has a kinetics, toxicity is very minimal. Methylene blue has no anaphylactic reaction, unlike vital blue has 1% anaphylactic reaction, any other blue dye for sentinel node. So that's why when you give, you should tell the anesthetist they may develop anaphylaxis. You have to keep adrenaline and noradrenaline and steroid. It also interferes with the pulse oximetric reading of the saturation because both have the same range of the light. Methylene blue doesn't have such anaphylaxis, but if you give intradermal, it causes skin necrosis and it can have a tattooing effect. These are the two important issues you must know. ICG doesn't have such tattooing effect, doesn't have skin necrosis, doesn't have anaphylaxis, which is proved. So the beauty of ICG is its half-life is 180 seconds when you give IV. Then it is excreted through liver and bile. But when you give soft tissue for SLNB, it can stay for about 1.5 hours. So you can safely do a surgery in that window. Unlike when you do blue dye, you have to do within 8 to 10 minutes and technetium within 2 hours. So that's why ICG is preferably used. What is the light which is used to excite? 700 to 800 nanometer. And the depth of the probe currently is 1 to 2 centimeter. ICG binds to albumin. When you throw 700 to 800 nano, it fluoresces at 840 nanometer, even seen 2 centimeter below the skin. That's why in axilla, even before you keep an incision, you can look back like this. Primary site of injection, lymphatic and axillary node. And they look fluorescent node. So sentinel node could be blue node, hot node or fluorescent node. So this is the first validation study which is published from our group, Rohit, Ashwin and all our group, where in Indian woman isolated single ICG was done and it was proved that the false negative rate was less than 5% and then sensitivity specificity was very high to the tune of 100%. And after this, it was presented San Antonio. Then we undertook 100 cases of 2-arm study. One arm is sentinel lymph node using ICG alone. Another arm is gold standard, which is technetium with handheld gamma probe and blue dye. This is published in the best journal in the breast cancer, the clinical breast. You can go back and read. So what this showed is ICG alone is equivalent and superior to dual technique. You don't need nuclear medicine department. You don't need expensive probe. You don't have to wait and give dye 2 hours before. After patient is anesthetic, you can give. It is a dynamic imaging And now in a country like India, single ICG is more or better than both of them, can be practiced in peripheral unit without need for nuclear medicine center by any surgeon. And my paper is used in a meta-analysis which is published by the, you can read, go back and read this from London, Imperial College of London. And based on our study of 100 cases, now it is high level of recommendation in forest plot that ICG based SLNB is a very high level evidence, better than both of them. So based on our study, the ESMO has included ICG as one of the sentinel lymph node, which is possible. So you can go back and read this meta-analysis and my publication, which is available, the only trial. Now, is the sentinel lymph node good, adequate? So this is the analysis which is done from India. Axillary recurrence in sentinel node negative patient which are followed. I told you all the recurrence happen by 20 months and worldwide 0.3% is the node recurrence. Now look at this study from our group, 8,221 sentinel node negative, followed up for 20 years of the patient. Sentinel lymph node, you can see most of the time sentinel node is less than 3. However, lot of residents in my hospital keep doing it. 11% had more than 3 nodes, which is not right. More than 3 nodes, if you have less false negative, but morbidity of axilla then goes equivalent to ALND. So isolated axillary recurrence in SLNB group in India followed is 0.2% only, and in breast it is 2.6. So it is published. You can go back and read this. So you can see that isolated axillary recurrence is 0.2. Remember, when you do a SLNB, typically what is the false negative rate? 3 to 5%, which means in 5% of the patient, you leave a positive node in the axilla by mistake. But the beauty is all 5 don't recur, less than 1% recur, because systemic therapy given in the form of chemo or radiation to breast, not to axilla, also controls the local disease. Also, there is a concept of stem cell that, a node with a stem cell only metastasizes out and not. This is a Umberto Veronesi's concept. That's why even though 3.5 to 5% of the time you may have missed a positive node in the axilla, 5% is not the axillary recurrence, it is less than 0.2%. That is the beauty. And there is no change in the survival, because axillary dissection in this modern era of systemic chemo, anti-HER2 therapy, hormone therapy, radiation, breast conservation is no longer considered therapeutic. It is more of prognostic, staging, giving information, reducing recurrence. So the survival benefit comes from primary tumor resection and systemic therapy. So there is no alteration in the overall survival. So positive node in axilla automatically doesn't mean you have to clear, because if you do sentinel node, and if you missed a sentinel node, positive node in SLNB where 5% is FNR rate, still it doesn't compromise the overall survival. So understand the concepts what I'm telling as a student. I know a lot of first year students have taken it is difficult to digest. General surgery mindset, you have joined onco, but these are the concepts you need to understand. But however, that is not an excuse to omit ALND. So you should not say, oh, Dr. Somashekhar sir told me axilla is only staging, not therapeutic. Axillary recurrence, even if 5 times you leave, manifests only 0.2%, doesn't matter. No, staging is mandatory. You must do sentinel lymph node and prove positive or negative, because 60% of the time SLNB is the only positive node. And then when you have staged the SLNB as positive or negative, then the medical oncologist tailor makes their adjuvant treatment, radiation oncologist tailor make. That is when the recurrence is 0.2% and overall survival is not altered. If you don't even state the axilla thinking it is N0, then the errors are huge. 40% you miss the node. Based on that information, medical oncologist de-escalate, so overall survival compromise. Based on that information, radiation oncologist de-escalate, so again there is more recurrence and you don't know what to tailor make. So understand this concept. Staging of SLNB mandatory. And when you do adequate SLNB properly, FNR may be 5%. With modern era of adjuvant, the recurrence is still 0.2%. So this is a paper, you can go back, you'll understand the concept, what I meant. And we found in Indian patient, all the recurrence, 0.2% of 8,000 happened within 15 months. So breast cancer recurrence, triple negative, 5 years you follow, you're through. Hormone positive, 7 to 15 years, delayed recurrence. That's why ATOM study, long-term hormone therapy for 7 to 10 years is important. Axilla, by roughly 20 months you are through. So this is the important landmark you must understand. So this is the papers which showed that methylene blue can be the alone advantages. It can be done in India, easily reproducible, commercially available option is available. Now I'll go into the concept of if you give neoadjuvant chemo, now more and more 60% of the women receive neoadjuvant chemo not because they are LABC, because all HER2 positive tumor, the moment they touch 2 centimeter, they need neoadjuvant chemo, even though they are operable, even though breast conservation is amenable at presentation. All HER2 positive breast cancer, even though they are stage 1, T1N0, M0, even though at presentation breast conservation is possible, even though at presentation Slnb is possible, as per the current guidelines, should receive neoadjuvant chemo anti-HER2 therapy and RCB index, residual cancer burden. I will cover this in my talk later. What does all this mean? Needs. All the triple negative cancer patient, if they are 2 centimeter, 20 millimeter and above, should receive neoadjuvant chemo. All big tumors, if they are not amenable for breast conservation but can be downsized by chemo, needs, and all LABC stage 3B needs. So these are the indication for neoadjuvant chemo. Remember this. I've told it again. I cannot repeat it again because want of the time, breast is a very vast concept. It took 30 years for me to master this. I've read over 10,000 papers and about 20-30 papers and 1,000 journals to accumulate the knowledge which I'm sharing with you. I cannot give more concept, but just understand what I'm trying to do that. Now the concept of can sentinel lymph node be done if you give chemo first? What if sentinel, if the channel fibrosis, sentinel node is not adequate, will FNR rate be high? If you want to do sentinel lymph node, if you plan a chemo, should we first do sentinel node, document the node, negative, positive, give chemo, then do only primary breast cancer later? Or should we finish the chemo and do it? What are the advantage, disadvantage? Number one, if you do Slnb before starting chemo, map the axilla and keep, very accurate, very easy, lymphatic channels are patent, false negative rate is less than 3.5%. Then you know positive or negative. If it is negative now, whenever you do surgery primary, you have to just do primary. You don't have to go to axilla if it is negative. If it is positive, you can go and clear. This is the advantage of doing upfront. Disadvantage, even if you have a node positive 1 to 3, 60 to 80% of the time chemo will sterilize this. See, when we have a bulky tumor in the breast, we reduce the size so we can do breast conservation. Unlike the oral cancer, breast cancer, the margin is taken from the tumor that is left behind after chemo. In oral squamous cancer, even if you give neoadjuvant chemo, the primary excision is not what is left behind, but what was there before chemo. But in breast, the margin is what is left behind, 2 millimeter negative margin, 10 millimeter macroscopic, pathologically no ink, negative margin is the margin. So if you can give the benefit of downsizing to primary tumor, why not in axilla? If there are 2 node positive, if you are given chemo, they are sterilized. They can also have the benefit of minimal access axillary surgery, because the complication of breast surgery is not primary. It is not a mastectomy or other. It is axillary lifelong problem, lymphadenectomy. So these are some of the concepts of before and after. NSABP B27, please master all the trials name. NSABP 18 and 16, breast conservative surgery in a patient premenopausal, postmenopausal, comparing mastectomies. Then NSABP 17. So the trial which gave neoadjuvant chemo in a big tumor, you downsize it and then you do the BCT. If you do upfront breast conservation, the recurrence is 11%. If you give chemo and do 7.6%. You must remember, I remember all the NSAB trial in my brain, why it is done, all the percentage in my trial, all the trial. You must master them. NSABP 27 is a trial which looked at sentinel lymph node after chemo. The Sentinel trial is a trial which told do Slnb in NACT group before. Sentinel trial is Slnb before giving chemo. NSABP 27 is Slnb after giving chemo. Please read about both. I will tell you the bottom line. Okay, I don't want to work around. Now the current concept is, if you are giving neoadjuvant chemo to sentinel lymph node after chemo, still the false negative rates are less than 5% if you do axillary clipping and ultrasound guided biopsy. And 60% of the patient axilla is sterilized, they have benefit of minimal access surgery. So as I told you, I can't spoon feed you. I can just stimulate your mind, show the path, you have to walk, read about those trials. So now this is something which is very important to understand, that even when you do a breast conservation with SLNB, IBRT, ipsilateral breast tumor recurrence, remember this, understand this, IBRT. If there is a second tumor in the breast more than 2 centimeter away from the primary site, it is thought as second primary. So you must understand the difference between synchronous and metachronous. Recurrence in a operated treated breast cancer versus second primary. Loosely, the definition is more than 6 to 12 months, 2 centimeter away. Same with head and neck cancer. Okay, it should be more than 2 centimeter from the primary site and with an interval of about 12 months. So they are then not counted as a recurrence. So you know, in situ component, histopathology of the primary and the secondary should be different. Receptor grade may or may not be different. So these are some of the differences to identify synchronous, metachronous, recurrence versus second primary. Okay. So the conclusion was Sentinel node is feasible after chemo as long as you do a good axillary clearance. And this is a paper, you know, this is a coded paper where it showed before starting chemo, do the high frequency ultrasound of the axilla, apply the sound trial. If it is suspicious, core that node, and if it is positive, clip that node, like how you clip the primary. So if you clip this and then when you finish the chemo, go and retrieve this clip node, targeted axillary dissection, the FNR rates are still equivalent to doing upfront. So the answer is, sir, after chemo, if you do SLNB, the false negative rates usually are high in the tune of 7 to 10%. So if you have a dedicated unit where you can do a pre-chemo ultrasound of axilla, clip the node, and later you do a targeted axillary removal of that node, clip node, then the false negative rates are equivalent to upfront. If you don't have this facility, please do SLNB before or don't do SLNB. Okay, this is something which is very important to understand. So also Asseco's Z1071 is a trial which showed if you don't do ultrasound of the axilla, don't clip that node, and then do SLNB after chemo, FNR was 12.6%. So that's why you must clip it and do it. So you must understand the trials for and again. Sentinel trial, NSABP 27, before, after. Asseco's Z1071 against, and other trials which is towards. Okay, these are some of the concepts. Now I have last 15 minutes to cover some important aspect. Having done Sentinel lymph node the way I taught, if SLNB is negative, beautiful, no need to do axillary clearance. What if it is positive? Should we observe, or should we do ALND, or should we give axillary radiation? As a student of oncology, surgical oncology, remember, if you have done a complete ALND, no matter what node is positive, we never give radiation to axilla. Adjuvant radiation after a complete axillary surgery is to the breast and chest wall, never to axilla. It is proved that when you have treated axilla completely by surgery, no matter 10 node positive, 20 node positive, 100 extracapsular spread, no benefit of axillary RT. No benefit in local recurrence, no benefit in survival, but intractable, life-changing, miserable lymphedema comes. So if somebody has not done axillary clearance or staged, you should go back and do Sentinel lymph node or do axillary clearance. If both are not done, that is the only condition where axillary directed RT is done. Okay, remember, radiation is not cost viable, surgery is more cost viable. So I'll come back to that. So if you have done a Sentinel node and if it is positive, what would you do? Now you have to understand the following concept. What is the impact of ALND and local recurrence? Is ALND therapeutic or staging? Extra information gained by axillary clearance, knowing SLNB, if you do, it will tell positive or negative, but it will not tell how many node positive, how many extracapsular spread, low burden, high burden. But by doing ALND over and above SLNB, if we get more information, does it impact adjuvant treatment? Does the long-term complication of ALND worse than EBRT? Do we overtreat all the patient with EBRT unnecessarily? What is the limitations and what are the evidence? And what is the quality of life issue? This is a screenshot. I want all the students to take a screenshot. This is a screenshot of what I'm going to speak now in next 15 minutes. What is it? If you do breast conservation surgery, If you are doing SLNB and it is positive, you can safely omit ALND. Asacos Z11 for breast conservation, Z011, MA20. These are the trial applied for Sentinel node and treatment in breast conservation. Amaros IBSG 2301 in mastectomy. IBCSG 23 showed when Sentinel node done micrometastasis, less than 2 millimeter is micro, more than 2 millimeter macro. Less than that anything is isolated tumors cluster cells which is equivalent to N0. Macrometastasis trial is Amaros. Remember all the trial, understand all of them. All these I kept in my brain. I know all the percent of pros and cons. Low risk axillary burden. Less than 3 node positive, no macroscope, no extracapsular spread. Z11 IBCGS 2301. High risk axilla. Multiple node positive, extracapsular spread, ER negative patient, young woman, poorly differentiated tumors. EORTC 22922 MA20. So these are some of the trials nutshell which analyze sentinel node is positive what we should do. Because the option is observation only, because the tangential beam for the breast conservation will go to level 1, 2, or axillary directed therapy if you don't want to do ALND, or extended field RT. Now Asacos Z11 Amaros MA showed if sentinel node is positive, they are low axillary burden, whether you do complete axillary clearance or you just observe and give the other adjuvant treatment, the survival is same, local recurrence is exactly same even in long term. Can you look at this? So they all concluded that if axillary node is positive, if they apply to this low axillary burden, it doesn't matter, because 61% of the time sentinel node is the only positive node. Even the paper I published in Indian group, 62% of the time sentinel node was the only positive. When you go back and see other nodes are not positive, so you are removed in 2/3 of the case all the positive nodes. NSABP 32 showed that if the sentinel node is positive, if you go and do ALND or other group you give radiation, then shoulder, arm, numbness, tingling, and then lymphedema are less in ALND. So that trial concluded RT to axilla is better to maintain quality of life with no change in local recurrence equivalent to this. IBCSG 2301 showed if you do a sentinel node, if it is a micrometastasis, no need to visit. It's proved micrometastasis, no need to remove axillary clearance. Followed up to 5 to 10 years. Look at this Kaplan-Meier curve. No change in survival, no change in axillary recurrence. Now, the outcome, sentinel node positive micrometastasis, axillary clearance done, no done, still the axillary recurrence is same, 0.4 to 0.2%. So now it is proved you don't have to go back in low setup. So frozen section, if you have a facility to do frozen, you should do that. Applying CAP guidelines, microtome set to 2 micron, multiple serial section, 7 to 8 section, 2 pathologists see together, then you can apply the concept. This is a paper which I published, how in India in the year 2014, you can see that the breast conservation rate was 32%. Now in India, it is 64.3% in 2020. How BCS rate is increasing, mastectomy has come down. This is a paper my breast surgery university fellow has published. You can go back and read this to understand how it is increased. So if you have a facility of frozen, yes, you should do, but it is not cost viable in a government setup. If you don't do frozen section for sentinel lymph node, revisit for margin and breast is close to 7 to 10%. So 10 out of 100 patient you may have to take back. But if you do frozen section, less than 1% needs revisiting surgery, but it is not cost viable. That is why you have to understand that if it is possible. If you have an ICG, it is better because nuclear medicine doctor is not required, very economical, not expensive. You can give it on table after injection. Sensitivity specificity is very high. It's a dynamic scan, no anaphylaxis reaction, and single technique can be done. This is the paper which I told you, which we have published. You can see that irrespective of wherever the tumor is, you need to prepare the ICG. It is on my YouTube. You can go back and read. You can type Dr. Somashekhar and my channel is there. It comes in a powder form with a filter. You put 10 ml of distilled water, 2.5 milligram per ml. Take it. There is a filter that comes fitted with ICG. You take it through the filter, so the particle size is 230 nanometer. Irrespective of which quadrant the breast lump is, whether there is a scar, not scar, previous lumpectomy done or not, single pinch the nipple, retroareolar sappy plexus you inject. use the ICG probe in front of your eye in few seconds from the primary through the lymphatic. It will go down and you can see that it sits there in the armpit. So that sentinel lymph node is very easily available there. Even before you start the surgery, put a incision, you can see. So you don't miss a first echelon node and falsely remove second echelon node here, and you can put an X there, and you can find when you go into the abdomen, the nodes fluorescence like this very easily, and you can go back and remove them. See this again, there is an injection done primary site. Even before you keep a incision in the axilla, already the node is seen there. So fluorescent nodes see very well, very easy. Then you can remove them and do this particular technique. You can learn them. So the study which I published showed that identification rate is very high and it is concordant, and intraoperative frozen section can be done with a false negativity less than 5% if you use a CAP guideline. So this is the ASACOS Z11 update we have now. Update at the level of 10 years. SLNB positive but no ALND done in a ASACOS Z11 group of patients, less than 3 centimeter, early breast cancer, low axillary burden, SLNB is done. The DFS, OS and clearance is same. Remember, this is not to be applied in a high axillary node burden we have in India. So ASACOS Z11 even at 10 year proved that the axillary recurrence survival is same in a low risk axillary burden, people undergoing breast conservation because radiation is already given, tangential beam cover the lower part. Amaros trial is a trial which showed, if you see now it is very clear that low axillary burden micrometastasis no need to do. What if there is a high axillary burden and macroscopic spread of the extracapsular spread? Two options. You have to go back and do ALND. Amaros trial showed instead of ALND, if you give radiation, the axillary recurrence, look at it, less than 0.5% practically. But the benefit is the lymphedema is lowest in radiation group. Worst is you do ALND and add RT. Second worst is ALND, least worst is RT alone. So Amaros trial showed that if you do SLNB, high axillary burden, instead of doing ALND, if you do RT, then survival is same, but the lymphedema is less. MA20 trial is the most controversial trial. This is the only trial which showed in a high nodal burden, giving internal memory node and supraclavicular has a survival benefit. It is not a very well accepted trial, but you must remember, if somebody asks which is a trial which showed irradiating internal memory and supraclavicular has a benefit, it is MA20 trial. So now I will summarize in last 5-10 minutes what I spoke. 1970, NSABP 04, Halstead principle. Now no breast cancer follow Halstead principle. Only squamous carcinoma oral cavity, vulval cancer follow. King's Cambridge, he showed NSABP 04 is a landmark trial. It showed that if node is positive, if you remove 15 node, actually recurrence is less than 3%. What is the number of node as per AJCC current edition to remove axilla for staging? 6 nodes. 6 nodes equivalent to SLNB. If the node is positive, 50 node if you remove, recurrence is less than 3%. Era of NSABP 4. Then we know radical mastectomy is not to be done. ALND is not a standard of care. No survival benefit, unnecessary morbidity. So this is the axillary, NSABP 04. Please read this. So NSABP also showed that, there is a group of patients who didn't opt for RT. There are some group of patients who never had any axillary treatment. But still in them, the recurrence should have been 100%, no, only 17%, which showed that all the disease left in axilla don't recur. Same thing what I spoke about, false negative rate 5%, still recurrence is 0.2%. Then we got an era of NSABP 32, SLNB, IEO Milan study, which showed that any tumor less than 5 centimeter, it should be done. So there is no difference in axillary recurrence in both the side. In India, I have already published. So the recurrence, even though false negativity rate is 5, the recurrence is less than 1%. This is next the era. NSABP 32 also showed 61% of the time that is the only positive node. Then we entered year 2000, where even if axillary node is positive, if it is micrometastasis, IBCHG and ATRAMS trial showed no need to do axillary clearance because survival is same. So IBCS trial, ATRAMS showed micrometastasis in SLNB, survival recurrence axillary is same, 0.2%, so no need to go back. Then we came to an era of 2010, where what if you have a multiple node, macroscopic node positive? If you're doing breast conservation, low axillary burden, less than 3 centimeter, Assacox 11 says no need to do. If it is a macroscopic node, high burden, then Otasar trial and Amaros showed you can go and give RT instead of this, and this is the next evolution. Assacox 11, Amaros, Otasar trial, and Nodal trial. Macroscopic positive, high axillary burden, you don't have to do ALND, but you can just give an RT. Then came an era of EURTC trial which showed 5-year axillary clearance. If you give Slnb and RT instead of ALND is same, but lymphedema is less. So these are all the trials. Look at this, what I have summarized. Micromats, macromats, breast conservation, mastectomy, and macrometastasis in Nodal trial. See, in Nodal trial, ALND with no observation. Then came an era of the contra. See, most of these studies are for breast conservation because RT is given. What if you are doing mastectomy, extensive multicentric patient, because you have done a mastectomy, it is not an LABC, no indication for radiation. Then doing positive axilla and leaving, can we leave it? These are the trial win mastectomy, IBCA 2301, ATRAM trial, which looked at in case of mastectomy, which are going back, and I want you to remember this trial, and which showed that the recurrence would be close to 9% if you don't do complete clearance. So that's one group where we may actually have to go back and do this. Now coming to new era of 2020-23. This is an era of Synodar 1, Sinomac trial, POSNOC trial, and then Sounds trial. Please remember this. I remember all of them. I want you to remember. This is a POSNOC trial, is a UK trial. My very close friend Amit Agarwal and the group is doing, where they say, now the benefit comes from the adjuvant chemo and hormone therapy. Even if you have a positive node, you do Sentinel node, stage them, tailor make your adjuvant chemo, RT hormone, but no need to remove all of them. These are the trial which are telling you can observe. Neither you can give, you have to give RT, nor you can give this, but they're not level 1 going on. Abstract form, this Taylor RT and POSNOC trial are done until further things come. High macroscopic nodal burden, we need to either do ALND or you need to give RT as of today. So what does the information change by doing extra ALND? If it is TNBC, it doesn't help in T1, T2, and T3, it helps. If it is HER2 new, most of the patients go neoadjuvant treatment, so it doesn't help much. But in premenopausal, it helps. Postmenopausal, this extra information gained beyond ASLNB doesn't help. In TNBC, you can see that it doesn't help if it is an early tumor because chemo is given to all, breast conservation is done, and RT is either way given. So when will the Sentinel lymph node alter the management? ER positive and HER2 new positive patients, if you are not doing upfront surgery, it helps in a premenopausal woman and postmenopausal. So the last part now is CalGB 9343 trial, which looked at breast conservation surgery in an elderly woman. We don't do SLNB or we don't give RT to axilla, can we do? Now it is accepted. Luminal A tumor, T1, T2 in a very elderly woman, which is 72 plus. Selected group of patients, we can observe them because their expected life of survival is less and recurrence is very, very low. Now last 4 trial last year, Sound, Insema and Nauticus. What is this trial? This is a very important trial. Sound means ultrasound. Before doing a SLNB, if you follow the Sounds criteria and do a high frequency ultrasound, there are 6 points which has been told. Sound trial, ultrasound axilla negative as per the 6th trial. No SLNB, no LND. In selected group of patients, they are equivalent to axillary clearance. So this is the Sound trial in SEMA. It's very difficult to replicate, so don't start applying tomorrow, but I want you to be available. That's why a good ultrasound of axilla is very, very important before you go in and do this. Read about this Staden trial. With the want of time, I cannot cover this MD Anderson, MSKCC, Mayo trial and the Taxis trial. So in conclusion, SLNB is a gold standard level 1 evidence for any tumor T1, T2 less than 5 centimeter, clinically and ultrasound axilla negative. Crime not to do it in Indian woman. Even in India, now the average tumor size has dropped down from 5 centimeter to 3.2. Breast conservation has gone as high as 60 to 70%. Crime not to offer, you can use ICG. If you are doing a breast conservative surgery, low axillary burden, micrometastasis, no need to do ALND, no recurrence change. Even if the false negative rate is 5%, recurrence is less than 1%. If you're doing mastectomy and it is not an indication for RT and sentinel node is positive, you need to do ALND. If it is a macroscopic metastasis, you can either go or high burden, go and do ALND or a axillary dilated artery. And these are the trials which are coming. So this is what ASCO says. Level 1, all women less than 5 centimeter, level 1 to do SLNB. Level 2.1, what is that? Neoadjuvant chemo you are giving and then you do SLNB. So level 2A is also a very high level evidence. Level 2.2, neoadjuvant chemo and SLNB after that, or omitting is axillary clearance as per the ASACOS Z11 trial. Recommendation 3 as of today, that if patient has taken prior axillary surgery, radiation, SLNB is not accepted in LABC, inflammatory breast cancer, in situ pregnancy. So these are not recommended. So you must understand where you cannot do. These are the condition you cannot do. It is rightfully also put in NCCN, everything I told. So I'll summarize. If you have sentinel node negative, no need to go back. Micrometastasis, no ALND. SLNB, low axillary burden, Z11, IBCSU23 says no need to do. No RT2 axilla, no ALND. MA20 URTC says high risk patient, comprehensive RT2 axilla. Amaros says that high nodal burden, consider intramemory supraclavicular, it's not a high level evidence. So this is how I would summarize. All tumor, first do high frequency ultrasound, sounds trial. Then they are N0, N positive. Okay. If they are positive on ultrasound sounds trial, USG guided core biopsy, node positive, no ASLNB, already analyzed, go for chemo. Then you apply NSABP 32 trial, or you can apply the Sentinel trial. If they are negative, you do SLNB. If SLNB is negative, no ALND. If SLNB is positive, micromats, no ALND as per IPCSD trial. If they are positive macromats, you see you are doing breast conservation or mastectomy. Breast conservation low risk, no need for ALND, no need for RT as per Z11 IBCGS trial. If you are doing breast conservation high risk, then comprehensive RT or ALND as per the Amaros trial and URTC. If you are doing mastectomy high risk, no need to go and do ALND, give RT. So the only place where you may have to do ALND is you're done mastectomy, there is no indication for RT, it's a low risk. Because RT is not given, you have to go back and do ALND. This is my own prepared flow chart, which is published in the recent paper I wrote, Recent Management and Concept of Management of Axilla in India. You can go back and read this. So thank you. That ends the talk. It's very vast. This is what I can actually do. I've already overshot by 10 minutes. I'll try to answer as many questions quickly possible, but I'll take one more question on NACT, so I'll be able to answer. And if I happen to take your clinics class or I'm your examiner, I'll try to answer the more questions. Number one, what is the best option for axilla and early breast cancer if patient refuse? Why will patient refuse SLNB? The mindset is never with patient, it is with you. You are not doing SLNB, that's why you don't do. If you explain the patient, it is crime not to do SLNB. You can be prosecuted for not doing SLNB. You are medically liable not doing SLNB, and tell the patient SLNB is superior. You may end up doing ALND 20 nodes. Pathologist cuts the node into 2 pieces and say negative. If you give one sentinel node, ultra sectioning, multiple sectioning, IHC studies, more chance of picking up SLNB. There is a trial, N0 axilla by SLNB, N0 axilla by complete ALND. 10-year survival is better in SLNB because they're truly node negative. ALND misses the true positive because pathologists take 2 sections. So they will not refuse, you refuse. If you explain them properly, they will not. However, if you don't have SLNB facility, then you should do blue dye, methylene blue dye 4 node excision. What is mentioned in Almanac trial. Or you have to do low axillary clearance level 1, level 2. But you give a morbidity. Any specifically, now only role of SLNB in DCIS is it is a multicentric high grade, and if you are doing a mastectomy. If 3 sentinel lymph node are harvested, is it adequate? Absolutely. Even 1 sentinel node is adequate, because if it depends on the timing and the technique. A true proof of pudding and concept is only 1 sentinel node. If you go right time, right way, only 1 you can do. But however, up to 2 to 3 is harvested. There is nothing called less than. If you harvest more than 3 node, you have done a sampling, no benefit of SLNB, morbidity is high. So number of minimum load harvesting 10 is for ALND, because in ALND you don't know, no, level 1 which node. Level 1 we have 5 node, level 3 you have 6 node, level 3 you have 4 nodes. So in ALND you don't know what it is. Remember, 10 number is not for staging. 6 number is for staging. If you don't have SLNB, 6 node removal blindly is equivalent to SLNB. SLNB targeted. 10 to 15 node is for therapeutic clearance. What dilution, how much? I already mentioned. It comes in a powder, add 10 ml of distilled water, shake it, take 3 ml. So each ml has 2.5 milligram powder. Take it through the filter. It is available on my YouTube. You can see that. Can lymph node, how many positive lymph nodes? If it is a high axillary burden, don't clip. They all need ALND. If it is 1 or 2 suspicious node on ultrasound as per sound trial, you can clip. Beyond 2, it doesn't make sense. It is a high axillary burden now. What did I teach in my talk? High axillary burden, you have to do ALND, or you have to actually go back and give an RT. So you can clip up to 2. We clip up to 2 nodes to remove. Beyond that, it has no benefit. How can we define high axillary nodal burden? The current definition is more than 4 node positive. More than 4 node positive is high axillary burden. Extracapsular spread is high burden. Any role of low axillary sampling? No. It is not a level 1 evidence. There is no randomized controlled trial which is high level done. Do SLNB or do level 1, level 2 clearance, or do blue dye directed 4 node. These are the 3 accepted technique. Blind sampling has no value. Blind, if you want to do level 1. What is the best option for axilla in early breast cancer if patient refuses? I already answered dilution. NACT, I told you how many clipped. Let me also see in chat box if there are some questions. What is the best? Oh, same thing has come back. So intradermal injection. I already told you intradermal, there is no much benefit. I'll tell you when I do intradermal. If somebody has done a breast lumpectomy, retroareolar and upper outer quadrant, now I have no sappies to inject. That is the only time upper outer quadrant into the breast parenchyma or intradermal I give. The only time is if somebody has removed a tumor retroareolar with a circummedullary incision and there is a scar in a small breast, I still need to do SLNB. Only condition then I give upper outer quadrant parenchyma and intradermal. Otherwise, tattooing effect, skin necrosis is high. So now everybody has switched over to retroareolar sappy plexus. I think there are a lot of other questions. I am very, very sorry. I have to end because it's too much. 30 years to 40 years of knowledge, 10,000 papers and too many. I cannot give it in 1 hour, but I will try to give it to you. So I hope it was useful. I will follow it up with one more talk on what are the concepts of neoadjuvant chemo in breast cancer. I think 3-4 weeks later I scheduled. Dr. DG Vijay is going to speak on LABC. These 3 should comprehensively cover the breast cancer. Then we'll have an LABC or early breast cancer case presentation from exam going student. These are the concepts. So in exam, remember I have given all the tips of answer which I ask as an examiner, my colleague asked. So go well confident. So thank you very much. Thank you Navneet Singh ji, and over to you.
Excellent presentation, Professor Dr. Somashekhar. Thank you very much for this presentation. And thank you very much, trainees and faculty members, for joining.
Thank you.